Depression affects more than an estimated 264 million people globally and more than 19 million American adults. This places depression as the leading cause of disability in the United States. For the World Health Organization, the illness is associated with increased mortality and many negative health outcomes. Major depressive disorder is defined by the Mayo Clinic as a mental health disorder characterized by persistently depressed mood or loss of interest in activities causing significant impairment in daily life. And I'll go into the diagnostic criteria in the next slide. But to mitigate the loss of daily function and quality of life from major depressive disorder, establishing clear and effective treatments is of utmost importance. Primary providers play a critical role in major depressive disorder, as approximately 45% of patients who commit suicide have visited their primary care provider in the previous 30 days. Diagnosing major depressive disorder is not as clear-cut as some other diseases such as diabetes. This is partially due to the fact that the pathophysiology is very complicated and not well understood, and presentations of major depressive disorder can vary widely from patient to patient. Some may have more mental or emotional symptoms, whereas others may have more physical symptoms. For the DSM-5, to make a diagnosis of major depressive disorder, a patient must be experiencing, for 2 weeks or greater, depressed mood or loss of interest or pleasure in activities, plus other associated symptoms such as diminished ability to concentrate or think, insomnia or hypersomnia, psychomotor agitation, significant weight loss, or other symptoms. A patient must have 5 or more of these symptoms to be diagnosed with major depressive disorder. Because the pathophysiology of major depressive disorder is not well understood, treatment can be really challenging. While 2/3 of patients receiving standard treatment elicit a positive response, the remaining third do not attain adequate remission from their symptoms and may repeatedly cycle through depressive episodes. After an initial episode of major depressive disorder, the rate of reoccurrence reaches 40%, and after 2 episodes, the reoccurrence rate escalates to 75%. Because of this non-response issue, it leads to the need for additional or alternative therapies for major depressive disorders. There's also been some push to shift the framework of treatment for major depressive disorder. What is considered successful treatment may vary from patient to patient. Successful treatment should be viewed on a continuum rather than black and white criteria. Jasecki and Nelson Becker, 2018, state changing the framework has shown to have positive implications for practice. The term treatment resistant has been described as a label and thought to be detrimental to depression remission outcomes. McAllister and colleagues have recommended using the term difficult to treat depression instead. So the shift from treatment resistant to difficult to treat allows for a more realistic and attainable picture and a chance for partial remission and ultimately improving patient outcomes. Patients' preferences should also be considered when determining the acceptable level of recovery. While the improvement in neuroscience and development of better allopathic treatments ensue, current guidelines for clinicians are geared towards the goal of complete remission of symptoms. And because of the burden of depression and other mental conditions is on the rise globally, it is critical we better understand treatment options for the large portion of patients who have treatment-resistant major depressive disorder. Allopathic treatments of major depressive disorder primarily focus on pharmacological therapy. 3 systematic reviews appraised discuss that to better research pharmacological therapy for major depressive disorder, we must also work to better understand the pathophysiology. Researchers seek to understand optimization, augmentation, combination, and switch therapies. Through appraising 6 randomized controlled trials relating to allopathic treatments of depression, we found the effects of including pharmacists in treatment planning on patient and medication adherence reveals promising results. While the study does not yield statistically significant improvement in patient response to treatment, shared decision-making has been shown to positively affect patient outcomes. Many researchers tested the safety and efficacy of adjunctive treatments for patients with difficult-to-treat depression. Gundas, Bruce, and colleagues' 2019 report deficits in GABA may be involved in the pathological process of depression. The trial demonstrates statistically and clinically significant improvement in HAM-D scores after 15 days with the addition of SAGE-217. The quick onset of symptom relief for patients who previously failed to reach therapeutic levels with antidepressants was noted. In 2019, Papuva and colleagues tested switching patients to a new SSRI or SSNI and utilized a rapid onset medication, esketamine, in the placebo-controlled study on patients with difficult-to-treat depression. Medications like esketamine may quickly provide a safe and effective reduction in depressive symptoms, which could be really important for patients with suicide ideation. The researchers added adjunctively using ziprasidone, an atypical antipsychotic, showed statistically and significantly decrease in HAM-D scores as well. SAGE-217, esketamine, and ziprasidone offer options for patients with difficult-to-treat depression. The addition of cognitive behavioral therapy in patients with difficult-to-treat depression was also noted in multiple randomized controlled trials. One study reveals statistically and clinically significant decreases in the GRID HDRS score at 16 weeks and 12-month follow-up for patients using cognitive behavioral therapies as an adjunctive therapy. While time and payment considerations may limit the use of CBD for some patients, the efficacy and low to zero side effect profile offers an option for difficult-to-treat depression. McAllister, Williams, and colleagues 2020 and Rush 2019 worked to define and shift the current framework of difficult-to-treat depression. The researchers urge to change the goal to be optimal symptom control, daily psychosocial function, and quality of life. They suggest the treatment goal should be improved functionality in daily life rather than complete remission. The 2010 clinical practice guideline titled Practice Guideline for the Treatment of Patients with Major Depressive Disorder by Gallenberg and colleagues is broken down into 3 sections. Part A, treatment recommendations, Part B, background information and review of available evidence, and Part C, future research needs. This was done so different readers can easily locate the information most useful to them. This guideline is very comprehensive as it addresses the recommended treatment options for the many stages and various causes of major depressive disorder in adult patients. The recommendations are broken down into 6 categories, including 1. Psychiatric management, 2. Acute phase, 3. Continuation phase, 4. Maintenance phase, 5. Discontinuation of treatment, and 6. Clinical factors influencing treatment. To appraise the CPG, the Agree-To tool was used. This CPG was given an overall rating of 6, but the 6 domains scored differently. Domain 1, Scope and Purpose, had mixed results. The authors neglected to include health questions covered by the guidelines. Domain 2, Stakeholder Involvement, scored high overall, but was lowered because they did not include pharmacist input. As I discussed earlier, Research is beginning to show that including pharmacist input can improve patient medication adherence and overall outcomes, so it would be important to include this. Domain 3 looks at rigor of development. The fairly strong rating of this domain reflects that the authors used rigorous systematic methods to search for and develop evidence-based recommendations. Criteria for selecting the evidence wasn't completely specific, but the authors did discuss that this guideline has a broad scope, which could explain why the selection criteria was not very specific. Domain 4 appraises clarity of presentation. The clinical practice guidelines scored very high in this domain, as the organization and presentation is very clear and concise. Domain 5, applicability, scored strongly. A very detailed description of treatment for all stages of major depressive disorder and the various methods of treatment are discussed in detail. Domain 6, editorial independence, scored straight 7s. The authors extensively and thoroughly explained this information in the section titled Financial Disclosure and Conflicts of Interest. Although not all domains were given a 7 rating, overall this guideline is of high quality and would be recommended for use without further modifications. So the rating overall was a 6.